was awesome.
Hi everyone, my name is Vincenzo Berghella. Welcome once again to another AJOG MFM live session on highlights this time from the March 2026 issue. Mo, again, welcome. How are you doing today?
I'm doing great, Vince. Nice to see you. Nice to see everyone. Thanks so much for joining. I'm Mo Mhatre. I'm a maternal fetal medicine specialist at Tufts Medical Center in Boston and the director of the MFM Fellowship at Tufts. We're presenting our March 2026 issue, and I wanted to share our format for those of you who are not familiar. We go through all of the spectacular work that's been published in AJOG MFM from this past month, and we're going to select 4 articles to highlight today. These are papers that are of rigorous methodology, and we're trying to really have a clinical impact or shape how you care for patients in the office or on the labor floor. And we try to identify papers also that are not only relevant to our MFM colleagues, but also to all of the other providers who care for pregnant patients, such as our generalist colleagues, family medicine docs, nurse midwives, advanced practitioners, and PAs. So we're using visual abstracts as a high-level highlight, but please read the articles in detail on ajogmfm.org. I'm going to put them here. Here's the list. And Vince, why don't you start off with the first paper?
Thanks. This is a paper on artificial intelligence, certainly the topic of the day. I can't go an hour, I don't think anymore. It's not like a day, but maybe an hour or half an hour without talking about AI in some ways. This is a nice article. Dr. Ayash and colleagues here putting together, there are some experts in MFM and artificial intelligence in academic research, publishing in particular, and there's a lot to do with our journal. Certainly, there are many current applications, including enhancing manuscript preparation, quality assessment, helping with peer review, and I love the trustworthiness check. Being able to use. I actually now have ChatGPT, my friend Claude, Gemini. There's so many, and I use them all the time. All day long, including for some of this academic research publishing. It is true that some of the publishers, including Elsevier, our publisher, Wiley, etc., do tell us to be careful and use it properly. But more and more, I think that they're allowing us to use it. Obviously, there are HIPAA issues. There are issues with data representation. You need to be aware sometimes of hallucination that these language models have, and that's why at the end, whatever you're using it for, you need to verify it and check every word and generate it. But certainly more and more, I think I am actually incentivizing our young researcher to use AI in some ways during the research project from the beginning to the end. So read this article. I think there's some nice tables, some nice tips, some good references, and this is a topic that changes all the time. And I'm sure more, will come out.
Absolutely, definitely are shaping our future in research and obstetrics and beyond. Our next paper is a systematic review and meta-analysis on the effects of dental treatments on reduction of preterm birth. We have long seen an association of periodontal disease with preterm birth, but there was a Cochrane review, I believe it was in 2017, that tried to really identify if interventions on dental disease and treatment actually reduced the preterm rates, and the results were inconclusive. And a meta-analysis showed that potentially there was some heterogeneity that affected that Cochrane review result. And since that time, there's been 2 additional RCTs that have come out to evaluate periodontal treatment on preterm birth. So these authors wanted to do a up-to-date of the latest evidence and really see, is there any evidence suggesting that preterm birth rates are affected by the periodontal treatment in pregnancy. So they looked only at RCTs. It was very rigorous methodology, focusing on RCTs, really using evaluating the integrity of these studies with a very structured approach. And they were comparing about 4,000 patients who underwent periodontal treatment, compared to almost about just under 4,000 who had minimal to no treatment at some point in pregnancy of all types of dental disease and dental treatments. What they found was that there was potentially some association between having periodontal treatment in pregnancy and the rate of preterm birth. And they found an absolute risk reduction of perhaps preventing 20 preterm births per 1,000 individuals, which, given how often preterm birth happens, this is important. I think the challenge that these authors found was that there was a lot of inconsistency, heterogeneity, and some degree of bias in a number of the studies. And because they were using that rigorous methodology, they were able to really evaluate that well. And that found it really hard to actually tease out which treatment actually caused an effect, how much was that association. And so the jury is still out. We know that there's some association, but really trying to tease out what is most helpful is still a question for us. And certainly a well-powered RCT would be needed to answer this question adequately.
Yeah, interesting. The root scaling and cleaning seems to be the one that has at least been studied the most. And it's probably good for us, anyway, to keep our teeth clean and healthy. And, if it decreases preterm birth, even better. The next one, it's on maternal position, something that we talk about all the time with our midwives, the obstetricians, and providers in general. And this one about using different maternal positions that just laying down to reduce OP malposition, improve vaginal delivery rates. Again, another systematic review and meta-analysis. You can see here some examples on the left side of the fact that it looks like positions could facilitate rotation to OA in the first stage of labor. This graphic abstract they did in this case talks about changing position and changing outcomes, especially starting at 3 to 5 centimeters. So sometime in the first stage, changing positions could promote both vaginal delivery and spontaneous vaginal delivery. So again, both a kind of a reduction in malposition and increase in what we want, vaginal delivery. You can see some of the stats: increasing change into OP2A 2.4 or 5 times, increase in the incidence of vaginal delivery, and increase in spontaneous vaginal delivery. One of the things that was difficult, like in the previous meta-analysis, when you include so many studies, is exactly what position and when, to do. They highlighted the lateral position with their upper thigh flexed was found to increase, again, spontaneous vaginal delivery by 27%. So that's certainly one to consider. I'm just glad when I see, again, things that are done all the time by different obstetrician midwives, and finally some data saying, okay, we're not crazy. Some of the stuff actually does help correct the malposition and increase vaginal delivery. So really well done study.
Excellent. And our final paper that we're going to present comes from a group in Australia looking at false positive cell-free DNA for prenatal screening and confined placental mosaicism. So, cell-free DNA specifically for trisomy 21, 18, and 13 is, commonly used worldwide. But there is as the science is rapidly evolving, there is increased applications of what's called genome-wide cell-free DNA, which is looking for, more rare autosomal trisomies, copy number variants, some microdeletions and duplications. And what the studies have shown so far is they do have a low positive predictive value. So I do know that a number of our societies are not recommending that we use these routinely because of the chance for a false positive. But in Australia, it's actually quite common, particularly in the private insurance population. And so this group wanted to really evaluate more, how often is there a false positive cell-free DNA result when we have these genome-wide NIPT, and what are the obstetric outcomes in those cases? And so this was a matched cohort study. I took 60 patients who had a high-risk cell-free DNA result with a normal anatomy scan and a normal amniocentesis, and they compared that to 120 controls who had low-risk cell-free DNA, and they followed them through the pregnancy and then did biopsies of their placenta, for 4 quadrants, and then DNA analysis of those. And they also looked at the obstetrics outcomes. So what they found was that a third of patients who had a false positive result were found to have confined placental mosaicism. And you can see a large distribution. There's not one particular chromosome abnormality that is associated with confined placental mosaicism. It is more often in, particularly in the rare trisomies and monosomy X, which is not surprising given what we know as well from routine NIPT. And there was no confined placental mosaicism in the low-risk NIPT results in our controls. They also looked at the birth weight percentiles, as well as rates of preterm birth and preeclampsia. And so there was no change in preterm birth or preeclampsia for these patients. There was a lower percentile on the for their birth weight, but there wasn't actually a difference in small for gestational age. So it didn't seem to dramatically change obstetrics outcomes. So I think this is really nice to have some data to show that this can cause a lot of anxiety in patients, and is often related to confined placental mosaicism, and really should have caution in using this kind of technology right now in screening for aneuploidies. Yeah, all right. Thanks everyone so much for joining, and nice to see you. We'll see you in April 2026. Take care.